So welcome to everybody. We're just waiting for the little after the top of the hour like we normally do before we get started. Thank you all for being here.
So Adam and Mario, just in case you didn't know, I grew up in Rochester, and I went to the University of Rochester Medical School, and my father was an anesthesiologist there for 30 years.
That's pretty cool. What part of Rochester did you grow up in?
Oh, right down the street from you. I grew up in Brighton.
Yeah, I live in Brighton, so
Oh yeah?
right over by the Divinity School. Yeah,
Oh, is that right? Okay. I'm behind the temple, Rosh Hashanah, not far
gotcha.
from the town hall.
Yeah, town hall's under construction right now, so we have a temporary one.
There was a nice article about Rochester in the New York Times last week.
Yeah, no, it's great. As you know, it's a great place to live. Great place to grow up, great place to raise a family. Also, a great place to be a vascular surgeon.
So did you ever have contact with Jim DeWeese or Jim Adams?
Yes, both.
Really?
I started doing research in the division in 2001 when I was undergrad at Cornell, and both were still on faculty. And Dr. DeWeese was actually the one who told me to pick vascular over cardiac surgery. And
Yeah.
I shared an office with Dr. Adams for 3 years, from my fourth year, my fifth year, and my third year. So I got a lot of mentorship from him.
He was the reason I went into surgery. Very
Little
funny
known
guy,
little known fact that he edited all of the chapters in Schwartz textbook of surgery and never got credit.
really.
Hello, everyone, and welcome to the March JVS Online Journal Club. It's a pleasure to be back as your Young Surgeon section host. I'm Brittany Frazier. I am with Prisma Health and University of South Carolina and Columbia, South Carolina. Welcome to everybody. We have two papers to present tonight. First one being impact of pre-procedural ambulatory status on clinical outcomes after endovascular revascularization in patients with chronic limb-threatening ischemia by Dr. Watanabe et al. Out of Japan. And then the other being the value of vascular surgeons in modern healthcare systems, a systematic review and meta-analysis from Dr. Ojeda and all et al. Out of Argentina and Brazil, as well as Colorado. Um, our presenters today, very much pleasure to have from Upstate, Dr. Figali and Dr. Arain, and then from University of Rochester, Dr. Doyle and Dr. Matabele. So sorry if I butchered those names. Unfortunately, the authors were not able to join us today, just due to the time difference. But these are the authors. And then Dr. Jorgensen and myself will be helping to facilitate the discussions. And very excited to get started. For little house rules, housekeeping, please do stay muted. Submit your questions or comments within the chat box. We may call on you to ask your question. This is being recorded for on-demand access later on. And then looking ahead to the next online journal club, that will be Wednesday, April 8th at 6 p.m. Central Time, hosted by Duke University and Dartmouth. And as an alert, there is a new format coming to the journal club, with further details to be coming from Dr. Humphreys. With that, we can get started with Dr. Doyle and crew. I believe we said was first.
Sure. Good evening, everyone, and thank you to the Journal of Vascular Surgery and organizers for the opportunity to introduce tonight's journal club topic. The first paper we're going to talk about is the value of vascular surgeons in the modern healthcare system. is one that touches on every aspect of our work, yet remains underappreciated in many institutions. Vascular surgeons are unique in providing longitudinal, complex care, guiding patients from medical management through open surgery into vascular surgery and hybrid interventions. We also serve as the hospital's safety net, responding to urgent complications from iatrogenic injuries to cath lab, TAVR, trauma, acute limb ischemia, and other vascular emergencies in the operating room. Our expertise enables other high acuity programs to function safely and efficiently. Despite this critical role, vascular surgery is often undervalued in traditional metrics like contribution margin or reimbursement. Much of what we do, emergency coverage, urgent consultations, system level impact, is invisible in institution accounting. Studies in the Journal of Vascular Surgery and analysis from the Society of Vascular Surgery highlight that many of us work long hours, provide primary call, and support critical hospital programs without commensurate recognition or compensation. This does have consequences. Vascular surgeons report high rates of burnout, driven by workload, call, physical strain, and work-life imbalance. At the same time, the demand for vascular care is rising, and the projections indicate a worsening future shortage of vascular surgeons. Without action, these pressures threaten both the sustainability of this specialty and the quality of care we provide. This makes tonight's topic and paper not only timely but essential reading for every vascular surgeon. Understanding and quantifying our value to health systems is critical, not only to advocate for fair compensation and institutional support, but also to recruit and retain the next generation of vascular surgeons and ensure our patients continue to receive high quality care. With that framework in mind, I'll turn the discussion over to Mario, who will walk us through the specifics of the systematic review and its findings. Thank you.
Thank you, Dr. Doyle. Let me just share my screen here. All right, so again, I'm Mario Matabelli. I'm a vascular surgery resident at the University of Rochester. I greatly appreciate the opportunity to present this evening. So Dr. Doyle gave a wonderful introduction already. So jumping into the primary aim of this paper was really to assess the interdisciplinary and financial impact of vascular surgeons in contemporary healthcare systems. The study is incredibly impactful. We do know that there's typically currently a workforce shortage amongst vascular surgery. Some quote around 80% of counties in the United States lack vascular surgery coverage. There are increasing financial pressures within the hospital system. Vascular surgery is a critical driver of healthcare revenue, and the study really puts a number to that. And interdisciplinary surgery is expanding, especially with vascular surgery involvement. And ultimately, hospitals should invest more in vascular surgery infrastructure. If you could see here on the right, the bar graph indicates that vascular surgery is the #1 consulted surgeon for trauma cases intraoperatively, despite the fact that level 1 designation does not include vascular surgery in-house, and they respond the quickest within an hour in the greatest proportion, as you can see here. This was a systematic review and meta-analysis. The included studies were compliant with PRISMA guidelines. The study protocol was registered with Prospero. There were several databases that were queried. Some of the larger ones were Medline, PubMed, and Cochrane. Studies were included from 2010 onward and were composed of cohort studies, a few RCTs, and economic evaluations. Nearly all of the included studies were observational. The majority were US-based. Though they quoted 14 as including financial data, I believe 9 were included in their final analysis. And healthcare spending models such as fee-for-service, RVU-based models were included, as well as mixed models. There was high heterogeneity amongst the studies, as was expected, but they ended up controlling for this in some of their subsequent analysis. The Newcastle-Ottawa scale was used to assess quality of each study, as well as the risk of bias, and several statistical methods were used for analysis. Ultimately, after inclusion, 29 studies were included, which included about 6,500 patients. So going into the results, who consults vascular surgery? We see here emergency medicine, ortho, trauma, and neurosurgery comprise about 50% of the top consulting requests to vascular surgery. And the reasons for intraoperative consultation and intervention are here. Hemorrhage control and ischemia were about 50% of the consult question, and the intervention that was subsequently performed predominantly was primary repair of either a vein or an artery, followed by graft placement and patch angioplasty. I will say that about 64% or so of the included studies only reported the reason for consultation, not the subsequent intervention. So do patients do better when vascular surgery is involved? They fairly unanimously found that there was significant perioperative improvement in perioperative outcomes and vascular surgery was involved, blood loss being a significant one. Preoperative consultation was associated with lower blood loss compared to intraoperative consultation, and planned consultations was also associated with less blood loss as well as shorter operative time. And as you can imagine, this is particularly important in the trauma settings where hemorrhage is a leading cause of preventable death, and vascular surgery is very well equipped to prevent exsanguination. An emergent vascular surgery consultation achieved nearly 100% hemorrhage control in this study and 94% successful revascularization, very low rates of subsequent amputation and in-hospital mortality. And another study also showed that intraoperative vascular assistance was associated with significantly lower vascular-specific complications by quite a good degree, 2.2% versus 22%. The impact of vascular surgery collaboration in oncologic surgery I found to be particularly remarkable. Not only improved outcomes, but greatly reduced positive margins. So preoperative vascular consultation was associated with lower positive surgical margins compared with intraoperative consultation, and elective cases showed higher complete tumor resection rates, 91% versus 70% in urgent and emergent cases as well. Here are a few representative images. Both of these patients, one with renal cell carcinoma involving the left renal vein and intrahepatic IVC, as well as pancreatic ductal adenocarcinoma abutting the aorta and encasing the SMA. Both of these cases achieved R0 resection with involvement of vascular surgery. And vascular surgery in collaboration with podiatric surgery greatly improves limb salvage. Multidisciplinary limb salvage programs were associated with 46% reduction in below-knee amputations. And in one study over a 4-year period, they found 42% reduction in overall amputation rate. Multidisciplinary wound care centers that involve vascular surgery, wound care, as well as podiatry showed 38% decrease in major amputation rates. So going into the financial impact of vascular surgery, we do know that there's a great degree of revenue generation based on vascular surgery work. Academic vascular surgery programs produce 6% of total hospital gross margin, which ended up being around $5 million, while accounting for only 3% of inpatient volume. So quite literally doing a lot more with a lot less. Vascular surgeons acting as co-surgeons in about 730 cases generated 16,200 work RVUs that corresponded to about 77 million in supply charges. And vascular surgery service lines generated 41,000 work RVUs and 4.25 million contribution margin in an additional study. They did find that the fee-for-service healthcare model generated the most work RVUs and revenues, and you can see here the included financial data within these studies largely were fee-for-service and several mixed healthcare models. They did find that endovascular procedures generated the highest institutional revenue while also improving operative efficiency. Endovascular procedures and thoracoabdominal repairs ranked among the top 3 procedures by average revenue. And aortic surgery procedures, endovascular plus open repair were the second most profitable service line in this particular study that contributed about $3 million to the health system. Endovascular AAA repair as well as open AAA repair generated similar total reimbursement in this study, but endovascular repair produced greater reimbursement per unit time, which indicates a financial efficiency to endovascular approaches to appropriate patients. However, despite the significant revenue generation by vascular surgery, there is a mismatch between productivity and compensation. Despite a nearly 130% increase in work RVUs and a fourfold increase in hospital margin in this study, surgeon salary support remained largely unchanged. We could see here that when comparing podiatry to vascular surgery generates higher absolute RVUs over time, yet hospital revenue and physician compensation are somewhat disparate. The sharp increase in hospital contribution margin and a fairly modest increase in salary support for the vascular surgery department. They did a pooled proportion of intraoperative consultations and found that 20% of complex operations involving urology, orthopedic surgery, and general surgery involved vascular surgery consultation. They did find a good degree of heterogeneity, nearly 99% in this particular analysis. So they did a meta-regression to really answer the question as to whether or not differences in consultation frequency explained the variation across studies. And ultimately, they did find that variation between studies was based on how often vascular surgery was consulted, not random differences and variation in consulting patterns between different institutions. So this is an incredible systematic review, ultimately concluding and several points for discussion that I found quite incredible. So vascular surgeons are essential intraoperative consultants. They're not merely a specialty service, but they also help to optimize and I think enable the service line for other disciplines. We must be wary of existing vascular surgery workload and capacity, as Dr. Doyle previously mentioned, that the degree of burnout amongst vascular surgery largely has a lot to do with the workload. Planned vascular surgery involvement is far better than intraoperative rescue. So reduced OR time, reduced blood loss, and fewer complications are all a result of early involvement of vascular surgery. Multidisciplinary models improve patient outcomes, improved R0 margins, greater limb salvage. Vascular surgery is integral in managing hemorrhage, ischemia, and complex vascular reconstructions. Vascular surgery generates significant hospital revenue, but compensation is not yet compensatory. We see that there's a good degree of hospital revenue generated by vascular surgery, and endovascular and aortic procedures are the greatest of these revenue drivers. There are a few limitations worth noting. So most of the studies were observational, despite a few RCTs that were included, and there was significant heterogeneity, but we saw they did account for this in one of their pooled analyses. Financial data was from disparate reimbursement models, and there were about 5 studies or so from outside of the United States, and the majority of them were within the US. So vascular surgery obviously exists worldwide, so knowing a little bit more about some of their consulting patterns abroad would also be helpful. So in conclusion, this evidence and many other sources of evidence suggest that vascular surgeons are not only specialists, but we're essential collaborators across many different surgical disciplines. We improve patient outcomes when we're involved in enabling complex procedures. We contribute significantly to the hospital revenue, and there's ultimately a need for greater recognition of our role in the healthcare system, the planning of healthcare systems, and the development of workforce across the institutions. Appreciate your time, and a special thank you to Journal of Vascular Surgery for the honor to present tonight. Thank you.
Well, thank you. I think that that's sort of an interesting, it's an interesting article, and it's very timely for where we are. Jens, you've been in this field for a little bit longer than a couple of us on this talk, or on this session. How have you seen this argument change over time, and what are some of your thoughts?
Well, I think that many of us are in the position of negotiating with hospital administrators for compensation. And so articles like this, I think, are an important tool for justifying salary. They help explain the value in the emergency room, in the operating room, and the strain on the individual practitioners. There's a lot of discussion about burnout these days. And certainly when you're getting called and distracted from your day job and having to cancel clinics or leave your operating room for a little while or coming in at night, that's something that needs to be considered. So I think that's the primary value, at least from my perspective, of using this for negotiation.
I thought one of the things that was fairly interested in here is that about 50% of the consults are emergency-based consults, in the OR that people have for hemorrhage control. I'd love to hear from Adam, Anthony, how you handle some of this stuff at your own institution. I try desperately to get our oncology surgeons to give me time to let me look at it, to plan at least a 1, 2, 3 different things. And it's an interesting concept that there are so many emergency issues. Why don't people talk to us before? Why do you think that some of that is an issue and that we see still, despite, knowing that a lot of the things we do are emergency based in the operating room?
Yeah, I would love to say that, we have the perfect setup. We don't. I don't think the grass is greener over here at SUNY Upstate. I mean, it's individualized. I think that level of communication and comfort, and I will say some of our, particularly in regards to surgical oncology, will communicate and then have us evaluate replace hepatics or tumor encasing in SMA, for example, and we will be available. And then I think sometimes it's maybe I think surgeon, toughness in a way that we can do, we can fix it. We don't need other people to help, and we all make that mistake. I do myself. It brings to light a recent case where I was at the VA and got called emergently for a young patient with a IVC injury and a Whipple, a young guy in his 30s. So, and by the time I got there, it was massive hemorrhage. The IVC was torn from the flexure down to the bifurcation, and I was able to fortunately fix it, but he ended up going to DIC and didn't survive. And so, and it was a tumor that was encasing the cave. And I think if we were present and there was that level of support, I think that it could have been avoided. So it's hard to know. But I think as surgeons, I think communication suffers, and we all make that mistake. And we have our egos, and we can manage things on our own. I think it's easier said than done in certain cases. But I mean, we're here to help, and I see one of my partners, Dr. Costanz, on the call, and I think it's not a unique situation just to one institution.
Yeah, I can weigh in with a little perspective from the U of R because, we were down to 2 faculty at one point, and we're up to 9.5 at this point. Dr. Stoner has done a remarkable job of rebuilding our division and, building a kind of a more sustainable system by advocating for resources, support, physician growth, by looking at a lot of these things to get institutional support. We had 4 nurse practitioners, we're up to 10.5, so all of the different domains. And then whenever we have a quality issue, a non-planned vascular injury that, could have reasonably been avoided, those are educational opportunities for lots of people. And so kind of taking a collaborative approach to, hey, we all want the same thing for the patient. We're all in it for the same interest. And talking to the surgical oncology PSN about is, part of the pre-op checklist, is vascular involvement expected? Yes or no? Is the vascular surgeon aware? Yes or no? So that way you can kind of make sure you have someone available to come and help. And then other kind of things that we've done with like the acute care service model, where we have a surgeon who's available Monday through Friday, 6 a.m. to 6 p.m., and a resident team to match, who's able to kind of come in and deal with all of the iatrogenic, all of the emergencies, all of the add-on stuff from the hospital, support transplant, TAVR, stroke center, all the things. And so then our elective schedules don't get disrupted. We don't have to leave clinics. We don't have to, abandon patients in the OR as frequently. It still happens from time to time. It's not perfect. But by growing our complement of faculty, by growing the complement of the trainees, by growing support from a hospital, we're able to, retain people on the faculty where for a long time we had high rates of attrition. And, using ACGME survey, we published 2 papers, one looking at hospital contribution margin and resource utilization, and another looking at surgeon resident well-being, where we showed that implementation of this type of model helped both. And so it's this type of argument that kind of, our trainees are happier, we're happier, we see our families more. And I think Mike's on the call. I don't know if he's able to talk or not. But really, it's kind of a remarkable turnaround of we face all the same problems that everyone else does, but there's kind of his approach has been kind of visionary in terms of fixing what was a pretty dysfunctional system.
Hey, Adam, I'll say one quick question. I would love to hear the faculty answer this question on the phone call. The big 800-pound, the question in the room is, should we get paid for this on the side? Should we have call pay, et cetera, because the RVUs don't translate to this work product as a fire person of the hospital? I'm curious what you guys think. It doesn't come out clearly in that SVS salary survey. It wasn't really easy to figure that out, but I'm curious what other people think about that.
I think that's an interesting perspective, and we're really struggling with that. Just this week, and it's happened twice in the last month, where our vascular surgeon was doing an elective case and they had to leave their elective case to go help with an emergency. And on both occasions, the vascular surgeon got written up by the hospital or by the nursing staff. The first one was because they left their elective case for a little bit to go and help somebody else, and so that delayed their case. And the other one was actually a trauma patient that had come in and they needed the vascular surgeon to come, and they finished their elective case and then went and helped with the trauma patient. And that person got written up because they finished the case they were in a critical portion of that they were doing before, and they didn't come and help immediately. And I simply wrote back in a nice, lovely way that we're not paid to provide 24-hour coverage for providers in this institution. We are paid based on our RVUs. And if you would like for us to provide backup coverage for trauma and all of your surgeons, I would be more than happy to sit down and talk about the funding for that and how we can do it. And I think that we get into these places where people don't realize the value. And it's not until we set boundaries, and I am horrible at setting boundaries, but it's not until we set boundaries and make people truly feel the discomfort that they start to realize, okay, this is a problem. Let's see what we can do.
What was the response, Misty, to that?
Most people don't respond back to me. They just sort of let it all go. And for the one of the things is for the one, ACS is actually coming up with new language for trauma. As you know, there's not a board certified vascular surgeon that's required to be in a level 1 trauma center. And so ACS is trying to change the wording that is for verification. I think there's going to be a public comment that comes out in the next couple of weeks, and I would encourage everybody here to say something, because even the new language is not going to say that level 1 centers need to have a board certified vascular surgeon. It's going to use a little bit more strongly language than what it says now, which is you need somebody who has vascular expertise. But then call a transplant surgeon, call a cardiac surgeon, call somebody else. You don't need me. It doesn't say that I'm valuable and you're not going to pay for us to be here. Then you're not going to necessarily get me all the time. I'm busy. And I know that's a really hard stance to take, but I find that if I don't, nobody really listens.
If I can try and address Mike's question, I think that oftentimes people tend to take our services for granted. And unless you stand up for yourself, they will continue to take you for granted. When I was in private practice, we got paid for call, as did orthopedics, as did most of the specialty services. Later, we became integrated into the practice plan of the hospital, and then it was part of our overall compensation package. But I think if you're in private practice and you have that leverage, absolutely, there is a lot of pain and discomfort that is associated with being on call, and you should be compensated for it.
Do you all see any difference when it comes to, as hospitals are moving towards more service line oriented organization? Do you see, is there a benefit to that, a negative effect of that?
I think there's a negative effect, right? I think vascular surgery getting lumped into a cardiovascular service line can be deleterious unless there's a vascular surgeon running the service line, because you get washed out. For us, we get washed out in the circulatory, mechanical circulatory support, such a high margin thing that you get washed out in it. So I worry about this kind of service line structure. I mean, maybe a vascular only service line, right, with you and a cardiologist that perform vascular procedures or something. But as soon as you roll the word cardio into vascular, it's a big C and a little V. So I think it's something to be really careful about.
I appreciate that perspective, Mike, because we're looking to do something like that similar here. So, all right, Dr. Fraser, you want to continue?
Yes, excellent discussion of that topic. The next paper being presented by Dr. Figali and his team, Dr. Aram, is impact of pre-procedural ambulatory status on clinical outcomes after endovascular revascularization in patients with chronic limb-threatening ischemia.
Yeah, thank you for taking the time this evening. This is another interesting paper. I don't not as much of the financial impact as a vascular surgeon, but I think it looks at our outcomes. It looks at more of the impact of our pre-procedural ambulatory status on clinical outcomes of our patients after any sort of endovascular revascularization for CLTI. This is a study that really, there's not much in the literature looking at the baseline ambulatory status and how it affects after endovascular therapy for these CLTI patients. I mean, we have things that we look at like the frailty scores and functional status, but a lot of it negates this ambulatory specific, and seeing how good these patients do. And so these authors, even though there are interventional cardiologists, so it is a different kind of specialty, it's a different country in Japan, but they really look at pre-procedural mobility, and it should be a factor in decision making as a prognostic indicator in these patients. So with that said, I'm going to transfer over to my our second year fellow, Dr. Aram, and we'll go from there.
Thank you so much, Dr. Figali. Thank you, everyone, for this opportunity. Like Dr. Figali mentioned, it is very interesting paper and focus on very important topic that we deal with every day, and it's the impact of the pre-procedural ambulatory status on these patients. I have no disclosures, and so as we know, peripheral arterial disease is a manifestation of systemic atherosclerosis, and CLTI, it presents its most advanced stage. And CLTI, as we know, it carries a high morbidity and mortality, including major limb loss, severe functional impairment, chronic ischemic pain, and a psychological distress on our patients. And our goal in CLTI patients is to relieve the ischemic pain, promote healing of the ischemic ulcers, prevent limb loss, and improve the overall survival of our patients. So the pre-procedural and the options that we have the open option, open bypasses, and the endovascular therapy option. And many big trials came on this, the BEST-CLI, BASIL 1 and 2 trials. A lot of these trials, there was not like a direct comparison on the ambulatory status or the functional status of the patient. And that's where this paper came, is to evaluate the impact of the pre-procedural ambulatory status on the clinical outcome after endovascular therapy in patients with CLTI by directly comparing the outcomes across ambulatory status and the subgroup using real world data. This was an observational single center retrospective cohort, and it was performed at the New Tokyo Hospital in Japan. The study period was between January of 2010 and December of 2019, and the total population was 705 of CLTI patients. 15 were excluded due to failed to follow up for less than 30 days. So the final cohort was 690 patients with de novo CLTI who underwent endovascular therapy. The primary and secondary endpoints for this study, the primary endpoint was looking for a major adverse limb event at 3 years, and this defined as all-cause mortality in terms of the event, all-cause mortality, or a major lower limb amputation. And the amputation they were looking for above the ankle amputation, whether BKA or AKA. For secondary endpoints, they were looking for all-cause mortality, cardiovascular mortality, which they defined it as death that caused by cardiac causes, mesenteric ischemia, or limb ischemia. And and they also looked at major lower limb amputation. For the results, we had, as we mentioned, a total patient of 690, and they had most of these patients. They were they had an average age of above 70, and mostly were male. They looked at the risk factors that included diabetes, hypertension, hyperlipidemia, CKD, hemodialysis, ejection fraction. They looked at their Rutherford classification from Ford and above 4, 5, 6, whether they had wound in their feet, and the type of intervention that was performed. Those patients, after looking at the data, the non-ambulatory patients had a greater disease burden in terms of higher prevalence of stroke, higher prevalence of hemodialysis, more severe CLTI presentation, and also they had most likely those patients will present with a Rutherford classification 5 or 6. Most likely they will have heel ulcers, and all those patients that I'm talking about in terms of non-ambulatory patients. So then they looked at the in terms of the outcomes at 3 years for the non-ambulatory patients, and those patients had the highest risk of all-cause mortality, cardiovascular mortality, and major lower limb amputations. And then when we look at the Kaplan-Meier curves, it actually demonstrated a stepwise worsening in outcomes in terms of the ambulatory status. So the best outcome was ambulatory status without assistance, which is the yellow line here, and the worst outcome was ambulatory without assistance, and that was the blue line. And that in terms of major adverse limb events, all-cause mortality, cardiovascular mortality, and major lower limb amputation. Again, those patients, the non-ambulatory patients, they were mostly bedridden or wheelchair users, and they were ambulatory. In terms of the independent predictors of major advanced limb events, they were looking at those independent predictors. They were the bedridden patients, wheelchair users, ambulatory without assistance, age, and hemodialysis, and reduced ejection fraction, and Rutherford of 5 to 6. And those independent, those were the strongest predictor of the patients having major adverse lower extremity event. So then we came to the discussion, and it focused on 3 things that they are all connected in terms of, first, looking at mortality and the limb outcome. Patient with CLTI, which we know they already have extremely poor survival given all the comorbidities that they have, and the previous studies reported greater than 40% mortality at 3 years. Looking at our study in comparing and linking it with the ambulatory status, the mortality was actually 60% at 3 years. And this highlights the severe systemic disease burden in those patients with advanced CLTI. So this leads us to the fact that we need to look at risk stratification for those patients. So the pre-procedural ambulatory status should be incorporated in our decision-making for CLTI revascularization, because it can help estimate the limb salvage probability, the survival, and the overall procedural benefit. And this will lead also to our treatment strategy. For high-risk non-ambulatory patient, maybe primary amputation could be a reasonable alternative other than doing endovascular therapy. And for ambulatory patient at the same time, even with significant comorbidities, attempted limb salvage with endovascular therapy should still be, it's still justified. Looking at the limitations of this study, there were a few limitations that worth mentioning. This was a retrospective and a non-randomized design that was performed in a single center. And there we had about 40 patients that lost to follow-up for either because of relocation or change in contact information. And there was a lack of contemporary limb threat assessment. There was no mention how did they assess the wound? Did they use a Wi-Fi score, or how they were assessing these wounds? And also another issue was the incomplete wound data. Like we mentioned, the wound size, the infection severity, the tissue loss burden. But that being said, they had a plastic team who is taking care of those patients and taking care of those wounds in terms of debridement, requiring flaps, or any different advanced procedures. And the last thing, it was the frailty assessment limitation. So those patients, we know their CLTI, whether they have wounds or rest pain. So how can we tell for sure that they're non-ambulatory because of their functional status or because of the pain and the wounds that they have? And so in conclusion, I think it raises a really important point that made me actually think, and in the future, when we have one of those patients who are like looking at their ambulatory status and then think, should we really perform endovascular therapy, or maybe amputation might be the best alternative for those patients? That's why I think the pre-procedural mobility is a powerful prognostic marker in CLTI patients who are we are willing to undergo and perform endovascular therapy. And that concludes my presentation.
Thank you so much for that. How do you think that this ambulatory status compares with other prognostic factors like nutritional status, just the Wi-Fi staging, and any of the many frailty scoring indices?
Yeah, I think I think they're all kind of connected together because being not very functional, non-ambulatory, how are you making your meals, how much you're eating, and it all becomes like a vicious cycle. And then you have a wound in that, how that wound is going to heal if you can turn yourself or have the enough amount of nutrition. So I think it raises really good points. And unfortunately, most of our patients, they're I feel malnourished, and unfortunately they reach to the point they don't ask for help early, they always come late. And actually that's why it's kind of connected with what I'm working on right now at our facility at SUNY Upstate. We're coming up with an ERAS protocol for our amputation patients, and part of the things that I was looking for is nutritional status. So I came up with a order set that includes getting their nutritional labs, vitamins, what's their functional status, physical therapy evaluation prior to amputation, and pain team is also involved to help with blocks, so that, and come with a multi-modal pain control after. So I'm looking forward to this actually, and see how are we going to improve that in our patient population before implementing the ERAS protocol and after implementing the ERAS protocol.
Fawaz, that was a very nice presentation, very nice overview. And as everyone on this call is well aware, we are presented with an overwhelming amount of data and literature. And there are very few of us who have the time and energy to read the Journal of Vascular Surgery from cover to cover. And if so, we have to read it critically. And so it's sort of, as we read an article, or decide to read an article, there are a number of questions that come up. Should I read this article? What is the quality of the article that I've just read? Is it relevant to my practice? What is the takeaway message? So let's start right at the very top. Should I read this article? I was kind of surprised by the topic. What is the purpose of doing a lower extremity revascularization in a non-ambulatory patient? Many would say, so let me pose that question to you, Fawaz. What is the role for revascularizing a lower extremity in a patient who's not getting out of bed?
That's a great question. I mean, I don't know if someone who's non-ambulatory, what am I gonna improve or like improve their quality of life? Because most of our patients who come with CLTI, let's say with breast pain or wounds, we're trying either to get the wound to heal or their pain to get better. But if those patients who are non-ambulatory, I'm not sure if I improve their circulation, how is that going to improve their quality of life in terms of ambulation if they're already non-ambulatory?
Jens, I think that this topic that you're bringing up right here is super important. And I'd love to ask Dr. Fagali, Dr. Doyle, Dr. Stoner, do you have criteria for which you will do an endovascular repair for somebody who is perhaps bedridden, limited ambulation? I have my own criteria for when I will and won't do it, but I'd love to hear others' perspective on that.
Yeah, I think it's very individualized. We have a VA, which is right next to the buildings in the back. And just this evening alone, there was a call for us on the emergency room for a gentleman who had a failed bypass in Albany, ended up losing his leg at another hospital, comes now in, his other foot is also an issue. And this guy has been non-ambulatory. So are you going to put someone like this through the ringer and try to save something? Probably not. So I think with our VA population, we've really learned very well. There's a lot of data in that population with good follow-up, how they do. I look at it if they're going to heal. If they're going to heal an above knee amputation and they've got good inflow, then no. But there are cases where we do high amputations when they end up with wound dehiscence and healing issues, or we have to revascularize them. We've had multiple of these situations where we have to open up some of the aorta iliac inflow to get it. But in general, we have these conversations. Last week we had a patient, a week before, he was in their late 90s, MI, ischemic cardiomyopathy, you name it, he has non-ambulatory, not very minimally ambulatory with a dry wound. Then the question begs, is it even worth offering anything versus palliation and wound care, which is what we also go to. So I think it's very individualized, and I think it's good that at least our fellows go to a VA and we see a lot of this population. But I agree with Jens. It's this paper has its limitations. It's a single cohort. It's in Japan. It's done by interventional cardiologists. I found it very interesting that majority was POBA, very limited DCB. The stenting was very limited, so you don't know the cost and the technologies, and then further, why offer intervention these non-ambulatory patients? I think the value is it does show what we all know is that separation of ambulatory status and how they do long term with survivability complications. So I think kind of separating into those four categories is something that has not been done, which is what's unique in this setting. But to translate it to what we do, I think it's individualized personally.
I think one thing that's important is you have to look at what their quality of life is. And for many, it's very important to be able to pivot onto a commode and to get into a wheelchair. So if they've already lost one leg, saving that contralateral extremity becomes very important. I think it's a very different issue if it's only one leg that's threatened.
Yeah, that's my main criteria for doing a revascularization on patients who is non-ambulatory, is that they have a contralateral amputation just so that they can pivot. But most of the patients that I'm seeing that have two legs that are non-ambulatory, for the first one, I will tell them, and if it's the only one, it's not for the first one, if it's the only issue, then we won't offer them revascularization. But if they do have a contralateral amputation, we do try to save it.
Yeah,
So Anthony, you started getting into some of the issues related to the quality of the article. So let me ask Fawaz and Anthony, what are the criteria you use to assess the quality of an article?
Well, first, see if it's a randomized clinical trial. How big is the population? How many centers involved? And and I always read the introduction and read the last part and see what they're trying to compare and what they're trying to present in this study.
Mhm.
And then if that catches my eyes, then I go further.
So in this article here, we have a small sample size, and it's outside US. What about some objective criteria that people have recommended for writing manuscripts?
Um,
Anyone want to talk about the Strobe criteria or the Newcastle Ottawa?
Oh, look at you, Jens, bringing up some technique and stuff. I think that's great.
Well, do we have any volunteers? I think all of you should be very familiar with the Strobe criteria. It's a 33 or so checklist of an article, and many journals are now requiring manuscripts that are submitted to meet these criteria. And rather than go through it here, one of the important parts of it is it includes a flow diagram, and it starts with the beginning population, how the patients were excluded, and it ends up with the population that is under study. And either the Strobe or the Newcastle Ottawa, I think, are very important. And if you don't see that, and for a meta-analysis, you're looking for the PRISMA criteria. And the previous article did indeed meet the PRISMA. It said they adhered to the PRISMA criteria. So that's something I think that you should consider. So the next question is this relevant to my practice? Or, what am I going to do with this information? So let me ask again, Fawaz, what are you going to do with this information? You talked about that a little briefly. You're going to incorporate it into your planning and decision making. Can you expand on that a little bit?
Yeah, I think that was a great discussion that we just had now because I feel everyone, and like Dr. Figali mentioned, it's individual based, but I think having a criteria in my head that I should use it with every patient. And I think I was just discussing that recently with our chief, Dr. Costanza. So, and Dr. Humphreys mentioned that too. So patients who end up with 2 amputations, they end up, their transfer become harder. Then they end up with decubitus ulcer, and then also that also, like it just basically leads to their end in a painful way. Because as we mentioned, those patients are nutritionally deficient. They have a lot of other comorbidities. So with the first leg, I mean, when they come with the first leg with ischemia, if there is something we can do, we'll do it. But if it's too late, then I'll offer the amputation. Don't try. But then if they come with the second one, then I'll think about it twice. Do we really, is it too late? Can we improve something? Can we do something just for their functional status so they can have that transfer? Because it was also at the VA. We had similar patient. He had an amputation on one leg, and then a few months later, the other leg started.
I'm going to interrupt you right here because there are a couple of other points I'd like to bring up. I
Yes, sir.
apologize for interrupting. One thing that surprised me about this article was the results. Did you notice what the pre-op ABI was?
Yes, don't know it over the top of my head, but I have it here. Pre-ABI, yep, was 0.7.
That's ridiculous. I
Yeah.
mean, most of my claudicants have an ABI of 0.7.
Do you think that ABI was the best marker in here? When you look at the number of patients that they had, 61% of the non-ambulatory patients were on dialysis. So
Yeah.
is it that they have this elevated ABI? And is that even the best marker for what they potentially should have been using?
No, at least at TBI or pedal acceleration, because they're all diabetic and dialysis patients.
I think they also didn't use something that we're using a lot now, which to describe the wounds or to describe what we're looking at, which is the Wi-Fi classification. I know it's hard to go back and assign a Wi-Fi classification to a lot of these patients, but one of the things that drives some of the limb loss is just the extent of the wound. And Rutherford 5 and 6 is an easy way to say, okay, it's not that bad, it is that bad, but you can have a small wound that is on the heel or on the plantar aspect of the foot in a certain place where even though you're going to go back and revascularize it, just the location of it is not, or you still may not be able to get good limb preservation with a TMA or something along those lines.
Yeah, and I also think a big limitation was the tools. I mean, there was no bypass. This was a very simple POBA, the majority of the patients. We didn't see things of other adjuvant endovascular therapies such as lithotripsy or percutaneous bypasses or lymph flow. So it was a very limited, segment of treatment that is hard to extrapolate, as I would grade to the US and how we treat a lot of our patients.
Mm.
I don't even know if some of those technologies are available. I know that in some countries they're not. I don't know if they're all available in Japan.
Yeah. Do you mind if I just make a quick comment about,
Of
just
course.
because we can doesn't mean we should. And Dr. Soder and I are actually talking about this today. We have a very high rate of above knee amputation because we have a lot of non-ambulatory patients in our population, and we do a lot of what we call sympathy angiograms, where someone's kind of questionable, you don't really know, is there an easy fix? Minor wound, something that maybe you could heal if you get the ABI up and you offload. But a lot of times you don't find easy fixes. And a lot of times the etiology of a wound in a non-ambulatory patient is a pressure ulcer from a wheelchair or from being bedridden, which isn't going to change by fixing the blood flow. They're still going to have a pressure ulcer and you're not going to be able to heal it. And we had a discussion about how even in some of these cases where you have very high rates of mortality, even after above knee amputation, which is really the only reasonable thing we can offer to a lot of these patients, whether we should even be doing that, whether we should be doing hospice care, end of life discussions, and not really just doing it because it's the next thing to do. Um, so, in any case, selective revascularization on ambulatory patients that have fixable pathology and a long life expectancy, I think, is reasonable when they stand pivot, like Misty said. But otherwise, I think really it's a terminal disease process where we have to really have pragmatic conversations about life expectancy, and not just go down the path of least resistance of doing what we normally do.
Adam, when you talk to patients about that, do you use terminology? So I use the terminology palliative wound care and hospice wound care now whenever I'm writing or talking to the patient. And I know that sounds crazy, but they understand some of that. We're going to put you into hospice wound care, which means we're not going to be able to fix anything. We're just going to keep your foot and keep everything clean, or palliative wound care, something along those lines, depending on their life expectancy. And I think patients know those words a little bit, so it helps, but I don't think that everybody understands how sick these patients are, and especially if it's their first time coming to the doctor.
Yeah. No, I think that framing it like that is a not so subtle signpost about what's going on, and kind of giving them that context and educating the medical team and the family and all the other people who are involved in the decision making, about kind of the rationale. And if you pull up the NSQIP risk calculator for some of these folks, they come in with an AMI, they go on ECMO, they have multi-organ system failure, they wean from ECMO by some miracle, but they're on dialysis and they have two dead legs. Their life expectancy is extraordinarily poor. So you kind of have to be realistic with them. And when you have those frank conversations, oftentimes patients say, I don't really want an amputation if they're able to make that decision. And, then you kind of say, we understand that if this gets infected, it could be the end of the road. And they say, well, everyone's got to die of something. So we do have to do hospice, palliative, end of life care, and having those discussions with people, I think, is super important.
Misty, I think that's a very important message that you gave. Not every ulcer or gangrene needs to be healed. And if it's not painful and it's not infected, they can live with it for a while. You can manage it with dressings, antibiotics, and so on. And then, if it progresses, you can think about options like amputation. But just because it's there doesn't mean you need to do something.
Do you think that as vascular surgeons, we understand that, and maybe this is a vague or a jaded way to look at it, but nobody else seems to understand that. There is an aorta, you have to fix it. There is a wound, you have to fix it. A lot of times with anything, there is an occlusion in the SFA, you have to fix it. People come to us as vascular surgeons freaked out about everything they see. And then we have to re-educate a lot of people.
Absolutely agree. Yes. I mean, we're aware of the consequences of the treatment much more so than others are. And so I think that we have a bigger picture.
Anthony, did you want to say something, or I can leave us
I
with
was
that
going to completely
philosophical
agree.
part?
I don't think this is a universal issue, and we 100% know the sequelae and where the pathway goes. I had a patient today in the clinic who was 82, ischemic cardiomyopathy, on COPD on oxygen, has bilateral big comedy-like artery aneurysms. And question was, am I going to put you through major surgery, risk of respiratory failure, MI? He's had multiple MIs, and so his GI doc, he's on AFib, has had GI bleed, says, no, you need this fixed. And so it confuses the patients, and I think our responsibility is to see the forest from the trees and show what our view is as an overall picture. I don't think it's going to change, I think this is a universal issue, but it's our responsibility to kind of communicate well. And I think that's something we're good at as vascular surgeons.
I just wanted to make one more point. Fawaz, you pointed out very well that they adjusted for comorbidities, but they didn't take into account frailty. And that's part of the frailty index, is that you're looking at this patient bedridden, not looking good, and so on. And I think that would have accounted a lot for the outcomes that they reported.
Yep.
Thank you, everyone, so much. Two very important papers with lots of important discussion. Really appreciate everyone's time. As a reminder, before we end, next month will be Wednesday, April 8th, with more new format being rolled out. Thank you guys again, everybody, for all your contributions.
Thanks, everyone. Have a good night.
Thank you
for having us.